Welcome to Public Health on Call, a podcast from the Johns Hopkins Bloomberg School of Public Health, where we bring evidence, experience, and perspective to make sense of today's leading health challenges. If you have questions or ideas for us, please send an email to publichealthquestion@jhu.edu. That's publichealthquestion@jhu.edu for future podcast episodes.
This is Lindsay Smith Rogers. Dire statistics about birth outcomes for Black women in America have become front-page news in recent years. But this problem isn't new. In fact, it has roots in the very fabric of American society and healthcare, with structural and systemic racism at its core. In a new episode of Public Health in the Field, Dr. Rachel Burvall, an MPH student at the Bloomberg School, and producer Annalise Winnie explore the foundations of this crisis. What exactly is the Black maternal health crisis, and why are we just now talking about this longstanding issue? Also, stay tuned, because we'll also have 2 more episodes coming out in May that look at how the crisis can be solved, from the important work already being done and the big gaps that still need to be filled in legislation, in hospitals and doctors' offices, and in communities and at home. For now, let's listen.
Hi, I'm Rachel Burvall. I'm a physician and MPH candidate at Johns Hopkins Bloomberg School of Public Health.
And I'm Annalise Winnie, Associate Editor of Global Health Now and producer of Public Health in the Field. This is Black Maternal Health Week, which annually for the past 6 years has encouraged activism and deepened public awareness around a major crisis in the United States.
Celebrities, activists, and doctors came together to address the Black maternal health crisis.
Ongoing crisis facing millions of expectant mothers across the country, the racial disparity in maternal health care. For many, it's a matter of life or death.
The stark racial disparities in maternal health and infant health in the United States.
The silent crisis in our nation's maternity wards. African-American mothers dying at a higher rate than any other racial or ethnic group from childbirth.
Even the richest Black women are more likely to die than the poorest white
Dr.
women.
Shanice Wallace, this young lady here, died shortly after delivering her baby girl, Charlotte.
In this series, we'll explore the roots of this problem as well as solutions to it. And today, we're going to talk about the facts of pregnancy and childbirth among Black Americans and how and why the nation has come to recognize this crisis in Black maternal health.
But first, some important definitions. Generally, maternal mortality refers to the death of an individual during pregnancy, childbirth, or within 42 days of the end of a pregnancy, from any cause related to pregnancy or its management. But the understanding of maternal mortality and its related terms have evolved over time. Here in the United States, a pregnancy-related death is often used instead of maternal mortality to describe deaths of a birthing person during pregnancy or within 1 year postpartum, and that's regardless of cause. And a quick note, we recognize that not all birthing people identify as women. However, in this series, as we talk about the Black maternal health crisis and its solutions, we will be using women to describe birthing people. According to the Centers for Disease Control and Prevention, the CDC, Black women are 3 to 4 times more likely to die from pregnancy-related complications than white women. And most of the maternal deaths are preventable. Even more concerning, this heightened risk is present across all income and education levels. And it's not just maternal deaths that disproportionately impact Black and Indigenous populations. Black birthing people are more likely to experience severe maternal morbidity, including life-threatening conditions such as preeclampsia, hemorrhage, and blood clots, and experience increased incidence of other pregnancy-related complications impacting the infant, like preterm birth and low birth weight. According to a study by a group of economists at Stanford University, the wealthiest Black woman in California is at a higher risk of maternal mortality than the least wealthy white woman. And though the crisis is particularly acute for Black women, the challenges extend to birthing people in America more broadly. That same study, published by the National Bureau of Economic Research, compared maternal and newborn health outcomes in California to those in Sweden, a country with universal health care and high international health rankings, finding that even the wealthiest individuals and newborns in California, regardless of demographics, had worse health outcomes than the poorest in Sweden on multiple measures. These outcomes are not only tragic, they're a national embarrassment, especially because as a country, our spending on healthcare is through the roof.
We have really terrible maternal health outcomes, and that's despite the fact that we're spending more per capita than any other country on healthcare.
That's Veena Smith Ramakrishnan, a senior policy associate at the Century Foundation, where she works on issues related to maternal health and reproductive rights and justice.
I think that's where it gets really frustrating, where you see all these expenditures in health, but the outcomes really aren't reflecting the money being spent.
Beyond health spending, maternal health lags behind despite advances in technology and increases in access to care. We're moving in the wrong direction.
If you look at maternal health, on average, we're doing worse and worse and worse. From the last generation to the current one, we intervene in childbirth 500% more with major surgery, to the point where 1 in 3 people get major surgery to give birth and 1 in 10 of their babies goes to the NICU.
That's Dr. Neil Shah, a physician, Harvard University assistant professor, and chief medical officer of Maven Clinic, a virtual clinic for women's and family health.
During that same period where we're doing all of this intervention, actually neonatal mortality for term infants hasn't changed, but maternal mortality has gone up by 50%. So on average, we're doing terrible. Also, what we've missed in public health is that it's not just what happens on average that matters, because you can do better on average and leave some people further behind. And then you can congratulate yourself for doing better, right? But actually, disparity is widening. What happened with maternal mortality, in my opinion, is that the degree of disparity got so wide that it ended up impacting the averages, and that's when we started paying attention.
These are clearly shocking statistics, but they could have shocked us a decade ago or 2 decades ago. So why is the nation coming to confront this crisis now? Well, there are a few potential explanations. For one, the data that you've just been hearing about, it's only in recent years that it's become crystal clear.
You can't fix what you can't see, and you can't see what you're not measuring. And even though maternal mortality has been going up for decades, we didn't have a systematic way of tracking it in the United States. The reasons are a little bit wonky, but it turns out that death certificates are constructed differently by the state. And the way that you attribute a death to a pregnancy had been a little bit different. So it wasn't until relatively recently that we standardized the process of collecting the information. And it wasn't until 2020, actually, that we had reliable data that was representative of the country.
It's true. As a country, we didn't have a consistent and systematic approach to tracking maternal mortality. That is, until more recently, when public health organizations and maternal mortality review committees, known as MMRCs, started providing documented information to give a better sense of how many maternal deaths were occurring, where they were happening, and who was affected. First, a bit of history. The first MMRCs in the United States were established in the early 20th century to address high rates of maternal mortality. And while these multidisciplinary groups of doctors, nurses, midwives, and public health experts helped shape early maternity care, they were not widespread. It wasn't until the last decade that more states mandated their existence through legislation. Federal funding also helped ensure that data was consistently collected, analyzed, and published. In prioritizing maternal health in this way, we gained a clearer understanding of how poor maternal health outcomes are for subsets of the U.S. population and in general. There's another reason we've started paying more attention. The death of Dr. Shalon Irving, which in 2017 helped put Black maternal mortality in the headlines. Shalon Irving collapsed and died from complications 3 weeks after giving birth to her daughter, Soleil.
2 reporters, it was like gumshoe journalism at ProPublica and NPR, Nina Martin and Renee Montaigne, wrote a series of articles starting with the story of Shalon Irving, who was a CDC epidemiologist who studied maternal mortality.
Irving's mother, Wanda, said more in a 2020 TED Talk.
It didn't matter that Shalon had dual PhD in sociology and gerontology. It didn't even matter that Shalon had 2 master's degrees, one of them a master's in public health from Johns Hopkins. It made no difference that Shalon was a lieutenant commander in the U.S. Public Health Service, an alumnus of the world-renowned Epidemic Intelligence Service, a highly respected epidemiologist at the Centers for Disease Control, and president of her own diversity company. She was still a Black woman. A Black woman accessing a system that saw her as a stereotype and responded to her as such.
In January 2017, Shalon Irving suffered a sudden cardiac arrest at home just 21 days after giving birth. 6 hours earlier, she had returned home from one of several urgent postpartum visits to the hospital. And during those visits, she had pleaded in distress for help, but her concerns were dismissed. She had presented with elevated blood pressure, which during pregnancy can be a precursor to seizures and stroke, also known as preeclampsia and eclampsia. She didn't have a headache or blurred vision. Those are the telltale signs of preeclampsia. However, she was in increasing amounts of pain and knew that something just didn't feel right. Soon, she had also developed other symptoms like leg swelling, intermittent headaches, and pain that prevented her from sleeping. Under the guidance of the American College of Obstetrics and Gynecology, these symptoms should have warranted urgent intervention, yet her providers attributed her experiences to the stress of new motherhood. Even if her care team wasn't suspicious at first, she was a high-risk patient. She was 36 years old, which is considered advanced maternal age, with a history of fibroid surgery, a clotting disorder, and a prior diagnosis of high blood pressure. All of this warranted a greater sense of vigilance, one she was not afforded. An autopsy revealed that she had clear signs of hypertension, and thus her death was classified as pregnancy-related. As stories like Shalon Irving's came to light, more people started sharing their experiences too. Social media is full of posts that show excited, expectant Black mothers in elegant maternity shoots, with a link to a memorial site or a GoFundMe page appealing for support to help a child left without their mother because of her untimely death. Bringing these stories to the surface in news headlines or in viral social media posts made the crisis feel new, even though it wasn't. As is often the case with public health matters, powerful individual stories can help garner momentum around an issue. Inas Khalid Ahmadi, the Vice President of Equity-Centered Capacity Building at the National Birth Equity Collaborative, explains.
I have a long history in public health. I've been in public health for 20 years, and I started out in sexual and reproductive health. And when I came into the field, there was a huge focus on HIV, and that's where I started in HIV and STIs. We were looking at the global AIDS crisis, and I think that media was really effective in galvanizing folks. I think just because of the way our media cycle is set up, people will respond to the hot topics. And that's just kind of the American way. And I think people also respond to storytelling. And so when we have a great storyteller, we're able to kind of gather people's attention.
So it wasn't just who was at the center of the narrative. It was also about who was telling that story. Shalon Irving had an influential cadre of peers and colleagues in government who helped propel her narrative to the forefront and helped humanize the maternal health data that would be released just a couple of years after her passing. Her story was shocking not just medically, but because it showed that even the most educated, most well-connected, high-earning, and well-insured Black women were vulnerable to the worst maternal health outcomes.
Shalon's story made people listen up, but that attention has been hard-won. Here's how Dr. Jamila Parrott, President and CEO of Physicians for Reproductive Health, explains it.
This conversation is now really in the public domain, in our lexicon and in our language because of the work of Black women who have been organizing on the ground for decades in support of the health and well-being of Black women and birthing people in their community.
Women like Dr. Toni Bond or Loretta Ross, 2 of the 12 Black women credited with developing the concept of reproductive justice back in 1994. As noted by Smith Ramakrishnan,
yeah, we're standing on the shoulders of some giants, and I think that is always really inspiring me to come to work every day and do what I do.
The new rounds of published information and statistics on maternal health outcomes serve to confirm what advocates and communities and some physicians had long observed and discussed, that Black women were suffering. These numbers only help to highlight that point, that something had been going on to make birthing in America, and in particular as a Black woman, synonymous with adverse outcomes. The recent COVID-19 pandemic and the events of 2020, including the Black Lives Matter protests, also highlighted the long-standing inequities in our healthcare system and society at large. We've seen how these disparities play out in terms of who gets sick, who gets access to care, and who dies.
Seeing people get murdered, police brutality, and just people not getting treated the same.
The same heightened awareness around health equity helped to propel Black maternal health to the forefront of public discourse. where people have started to understand that maternal health is not just an issue of biology, individual choice, or behavior, but a systemic issue that requires systemic solutions. Smith Ramakrishnan adds,
I also think we're seeing, a lot more Black women in positions of power across the healthcare space, and we're advocating for our communities and our families and ourselves, really, in these spaces.
And that's no better illustrated than the work of Representatives Alma Adams and Lauren Underwood, who have used their legislative positions to develop the Black Maternal Health Momnibus Act of 2021, a multifaceted, bipartisan bill focused on improving maternal health outcomes among racial and ethnic minorities and other vulnerable groups. We'll explore the details of that bill later in the series. It's also demonstrated through the existence of Black Maternal Health Week, which is happening now. Founded in 2017 by the Black Mamas Matter Alliance, each year, the week of April 11th to 17th is dedicated to raising awareness and inspiring activism in support of Black-led maternal health initiatives. These are just two prominent examples of the work being done to improve maternal health outcomes. Taken together, the media coverage, the data, the advocacy have made racial disparities in maternal health mainstream. And that makes sense. We're talking about something as basic as the health and survival of mothers and babies. That's something that affects all of us, regardless of our race or background. It's about the way people can connect with the issue on a personal level and how we respond to narratives. As a society, in fact, we orient ourselves around mothers. Moms matter, as the saying goes. Maternal health is an important issue in that it's about the health and well-being of the family as a whole. When mothers are healthy, there is a ripple effect on children, partners, and communities. This is a sentiment echoed by the policymakers, community advocates, and physicians we spoke to. Maternal health is, in essence, the mother of all health.
Maternal health is really a bellwether for the health of a whole society. So if moms are unwell, society is unwell. And that's why every injustice in society shows up in maternal health, whether it's gender inequity, racial inequity, geographic inequity, when we think about maternity deserts in our country, especially in rural America, and even generational inequity.
So we're not just talking about pregnancy, childbirth, and postpartum. We're also talking about the broader social, economic, and environmental factors that impact health and so many other outcomes. And deep within those roots lies racism. And that's been defined so many ways, but one that felt particularly pertinent to this series was brought up in a recent Morgan State University panel by Dr. Kanika Harris, Director of Maternal and Child Health for the Black Women's Health Imperative.
Racism is above all a technology aimed at permitting the exercise of biopower, the tool that allows us as a society to regulate the distribution of death.
Whether we acknowledge it or not, racism is infused in how this country operates and has fed and contributed to the current state of maternal health. This, quite simply, is why solutions are so badly needed.
So that's where this story goes next. Join us the first week of May as we explain further what we mean when we talk about systemic solutions. We'll discuss solutions ranging from the individual to societal, and how tackling the Black maternal health crisis can be a case study for other equity issues.
Thanks for listening to this special series for Public Health in the Field. I'm Annalise Winnie.
And I'm Rachel Burvell. We hope you'll join us next time.
Public Health on Call is a podcast from the Johns Hopkins Bloomberg School of Public Health, produced by Joshua Sharfstein, Lindsay Smith Rogers, and Stephanie Desmond. Audio production by J.B. Arbogast, Holly Cardinale, Philip Porter, Spencer Greer, and Matthew Martin, with support from Chip Hickey. Distribution by Nick Moran. Production support from Catherine Ricardo. Social media run by Grace Fernandez and Shian Briscoe. If you have questions or ideas for us, please send an email to publichealthquestion@jhu.edu. That's publichealthquestion@jhu.edu for future podcast episodes. Thank you for listening.